kindly to go ahead.
Thank you, Dr. Kalita, and thank you very much for inviting me for this Northeast update. I'm thankful to Dr. Pranam, who specifically called me to give this talk. As you know, nowadays we do around 30% of the interventions in complex cases like left main bifurcation, CTO, and venous interventions. And then when you do this, a result should match that of surgeon. Because unless in these complex cases, the surgery, unless you do almost equal or better than surgery, it is not going to be taken by the patient and we are not going to do justice for that. So traditional angiography alone is not enough. Angiography has a lot of limitations when it comes to assessing the luminal dimension, vessel wall pathology, and the end result of stenting. OCT and IVS are increasingly available as intracoronary imaging modality that provide high resolution imaging for coronary arteries. Compared to angiography guidance alone, use of either OCT or IVS is associated with better procedure success, in-hospital outcome, and lower long-term mortality in both elective and acute coronary syndrome patients. So with this introduction, I just want to show those images. When you see image in OCT, it's just like a histology. You see the intima, media, and ventria. And when you see these images, both IVS and intracoronary OCT, you can assess the plaque characteristic. If you see the A slide, there's a calcium chunk there. You can see the fibrous plaque. All these you can see assessed by OCT and IVS. So you can decide what type of modality is better, whether it's a routine angioplasty, cutting balloon, or if there's a lot of calcium, you can use a rotator. This is you can really, in OCT images, you can really find out the tissue characteristic. You can see the first one is a homogeneous high black scatter. It's called low attenuation, fibrous plaque. Lipid plaque looks like that. That is typical characteristic, which is well defined. You can see in OCT. I don't have to go into detail. Calcium nodule you can see, and calcium plaque you can see in OCT very, very clearly. And thrombus. Thrombus, you can see the red thrombus, you can see the white thrombus, you can see the recanalized thrombus, you can see lot of things inside the coronary artery. Pathology, different type of pathology like fibrous atheroma, calcific atheroma, clots, what type of clot, is a recent clot or the old clot, black, is a red or white, retinal, everything you can see very clearly if you are doing OCT. When you was do OCT, we calculate the total area, we calculate the diameter of the vessel, we can calculate the percentage stenosis. This is how it's calculated. And if you are putting a stent, whether the stent is well approached or not well approached, you can see through the calculation. These are, I do not want to get into details, but this is how you see a OCT image and you calculate. This is the LED, you can see angio of the LED, this is critical block. You want to assess by OCT, what is the length of the block, what is the diameter of the vessel, and what is the maximum narrowing. That you can see with the OCT, we have seen the length of this is around 14 millimeters. So from normal to normal, so we know it is a 14 millimeter stent is required. You see the diameter is around 2.25 distally and 2.9 proximally. So you know the diameter and you decide what length and what diameter stent you would need it for this case. This is again after stenting, you do the OCT, you see whether it's well expanded or not. You can see the white dots surrounding the wall. These are the stent, well approached. Diameter, whether it is fully opened or not, that you can see. First one is a cross-section view. Second one is the longitudinal view. Third, you can see the stent. Whether if it's a, you can see the white. If it is white, means stent is well approached. All these informations you can get in OCT. These are malapposition. Sometimes when you put the stent, you do the OCT, you can see whether the stent is well approached to the wall or not. If it is not well approached, you can see it nicely. You can again dilate it so that it's approached. Because if the stent is not well approached, there's a high chance of stent thrombosis and restenosis. So this you can see very clearly. This is a dissection. Sometimes in angiography you miss a dissection. But if you do the OCT, you can see very clearly a dissection. This is the OCT image. In intravascular ultrasound, you don't see that clearly. OCT in bifurcation lesion, when you use two stents, it is very important to see the whether the stent cover all the wall and where you are putting the second where, proximally or distally. By doing the OCT, you can see the whole, this is the PTC where middle one and the other one is a stent. You can see it very clearly. In follow-up cases, patients are coming after stent, they have symptoms, you want to know how much is the stenosis, you can do the OCT and you can see whether the stenosis is minimal, homogeneous or moderate or it is heterogeneous. Depending on that, you can decide whether patient this type of instant stenosis will can be treated with balloon or will require cutting balloon or it will require rotablator. So the pathology of histopathology of instant restenosis you can study. This is the difference between IVS and OCT. IVS, you know, it is there for years together. Is what you do is the intravascular image. You just put a catheter and the IVS catheter is there, goes down, automatically scans, and principle is with intravascular ultrasound, it takes the image. But the image is black and white. You don't have to use any contrast. But while in OCT, you put a small camera, goes down, then you inject contrast, make it free, that wall of the that length of the artery, make it free from water, and the automatically the camera scans, take the photo, and you see. The advantage of OCT is resolution is on parallel, and you see the automatic playback is there. You can see all this pathology very, very clearly. It's a very high resolution. You can see the lipid, calcium, fiber, thrombus, everything, but more costly than intravascular ultrasound, cannot be reused. And penetration is not very much. You can see if the artery is very big, you cannot see the wall. So up to 3.5 millimeter artery, 4, you can see it very clearly. But intravascular ultrasound is a time test. It is there. It has been there for many years. No contrast is used. Picture is black and white, not as clear as OCT. But advantage is less costly and can be reused. That's very important for Indian context. And lot of data are there in IVS supporting that IVS is better than using IVS. The result is better than OCT because OCT has come recently for the last 10 years. Then I'll show you few cases. I know it's too late, but I'll try to show some cases what you do really day-to-day life. We have been in Apollo Hyderabad. I started at the OCT first in the country, and I have been doing it for last 12, 14 years. My first series was published in Indian Heart Journal, where we saw that series of 50 cases. It was published in Indian Heart Journal. We saw that OCT, by using this OCT, immediate result was fantastic. We could sometime, but in 30% cases, we had to change the size of the stent and balloon and some additional stent because in routine angiography, it was not possible. This is some of the cases I'll show you, very interesting cases. We use mostly complex cases, left main bifurcation, and wherever there is a complications we suspect we use it, and we use it quite regularly, almost 20 to 30% of our cases, we use IBS and or OCT. This is a 49-year-old male. He came to us with unstable angina. Look at left main critical block, bifurcation block. We decided to stent it because he came for most of the patients who come to us, me at least, they know that they're coming for angioplasty, not surgery. He was offered for surgery, he didn't want surgery, he was too young. So what we did is, you see the block, left main, so much critical block in the left main. So we use a technique called decay cross technique in this case. We put two wire in both LAD and LCX. Then we pre-dilated LAD and then we pre-dilated LCX and then put a stent in the LCX. And with using a balloon, we crossed it. Then we recrossed the LCX and then we did the first case. Decay cross has one cross and two cases. The first case we did it. And then again, we put a left main to LAD stent. Then we do the port, proximally we dilate, it's called port, the technical term. Then we did the second case. And second case, you can see these are two balloons, we are making the case. And that is the result, almost normal. So this is called bifurcation stenting by decay cross. And we used in this case OCT because OCT help us in sizing the L6, LAD and left main. We know exact size. Tracking the guide wire, when the second guide wire you put, you should put proximally, that is what will see it. Recrossing bifurcation stent and stent, whether in the end we did the OCT to see that whether the stent is well approached or not. So this is how it helped. First we did a pre-procedure OCT, and this OCT will only show the length, diameter of the left main, diameter of the LAD, and diameter of the L6. Then we balloon dilated. When you dilated the balloon, LAD and L6, the dissection, there is a lot of thrombus formation. We didn't know. Angiographically, we didn't see. So immediately we started glycoprotein 2B3 so that the thrombus, it doesn't develop clot. Then we put the stent first and then recrossed. You can see the where is, you can see that clearly in the OCT where we are crossing to the circumflex, proximally the second where you can cross it. And in the end, we saw this is the OCT, 3D OCT also we can see in this. In the end, there's a metallic stent of, we can see inside, like a film tunnel, you can see the stent inside. It's white, means it's well approached. It's all white, and that's the circumflex, that's the where, two wares they are going. You can see 3D inside the stent, and you are absolutely sure your stent is well approached. If there is somewhere that apposition is not good, you can take a balloon and do it. If there's a dissection somewhere, distal stent, you can always put a stent. This is the type of result we get it. You, in fact, it's just like endoscopy, what you see, or if you compare, coronary angiogram is like a black and white, we are doing those time barium swallow, but endoscopy, what we do is these are the endoscopy, like this OCT. You see everything and treat it. This is another case where he had a critical block in left main, LAD and L6, and this is the block. You can see very, very critical block in left main. We dilated LGL. We decided to stent it because he didn't want surgery. And most of the people don't, we tell them surgery, but they must have sucked everywhere they come for interventions. And we dilated LCH, we dilated LAD, and then that is the result after balloon dilatation. Then we position two stent, one in L6, one in LAD, and we did a mini cross here. We crossed the circumflex stent with the stent in the left main to LAD. This is called mini cross technique. And after crossing this, we recrossed the L6 where is out, and then we recrossed again, and then we did a we dilated the ostium of the circumflex stent, and then we did a two balloon, did a kissing balloon, and that is the end result, just like a normal heart. So I show you very complex two left main cases where we routinely would have gone for recommendation is surgery. First recommendation bypass surgery, but with all these gadgets, we can get result as good as surgery. And young patients, they don't go for surgery. We do this type of patients where surgery is contraindicated. Second thing, many patients, young patients, they don't want surgery, they come for this. So we do it. Now, this is the result, end result is just like looking normal artery. And at the end, we do the OCT just to see that all stents are well approached. And you can see the dot. Dot is that means it is stents is covering the wall. It's well approached stent. That is out. This is another case again. It's a case where this patient had stent earlier in circumflex. Now he has come with left main disease, and we put two wires in LAD and L6, and we did the OCT. You see the severe instant restenosis. You can see inside the cell growth, and outside the white one is the previous stent. So what we did is we did a rotablator. We took rotablated from left main to circumflex, and then this was a good result. Then we decided to put a stent from left main to circumflex, and then after that suddenly we see just distal to the stent there is some hazy area. When we are not sure whether the clot migrated, why it happened, or spasm, so we immediately took a OCT, and you can see a very large flap there. Right side, you can see a flap. I have focused it. So when there is a large flap, we immediately put one more stent there. And that's the result. Then we move to the LAD, where we moved to the LAD, dilated the ostium, that stent strut, and put one more 3 into 15 stent. And this is the result. So it's a complex case where there is a left main disease, there is instant restenosis, two vessel disease, and we could do it with the stent on the end. We did the OCT as I told you. And this is the last case. This is a young fellow who came from out of the state. He had acute MI, he went somewhere. They did a primary angioplasty. He was discharged. After 2 months, he started having pain again, hepatangina. So we did an angiogram. We had a suspicion that there is a ostium of the left main has disease. But for the ostium, OCT is not good. It will not be able to show it. So intravascular ultrasound is the ideal. So we did the intravascular ultrasound there. That was the angiogram. You can see now around 70% block there in the ostium. So what we did is we take a 4.5 millimeter stent, short stent, and implanted it there, and that is the result. Angiographically is clear. This is the stent, and he has gone. He went back without any angina. So there is a trial called IVS comparing in PCI ultimate trial. Just want to share with the result. Result in those cases where IVS is used, this was published in 2021. The result, MACE, target vascular reversation, repeat reversation, everything was less. You can see the left side. Blue one was with balloon alone, and the red one is with IVS, intravascular ultrasound. That was the. But right side again, when the result after balloon A was suboptimal, either with balloon or this intravascular result was not good. So suboptimal, you shouldn't leave. You should use the intravascular ultrasound to get the best result. Then only we get the 3 years follow-up result. And if you use OCT, many times you find that 20 to 30% patients, you have to change the length of the stent or diameter because angiographically it is not clear. That is why when you do the OCT, you optimize the result so that the stent covers all the disease part and covers the wall well. That is the aim of the interventions using OCT or intravascular ultrasound. This is a new trial, Illumine trial with OCT versus intravascular ultrasound. It was shown that and balloon, and it has shown that the end result with intravascular ultrasound, immediate result, intravascular ultrasound and OCT is same, balloon is inferior. But there is a large trial going on, multicentric randomized trial to compare the outcome of OCT versus angiographic guided PCI. That result will come very soon, and I'm sure that result will show that OCT, if you're using the result, long-term result also will be very good. So, ladies and gentlemen, in performing complex PCI, angiography alone is not enough. Imaging modality like OCT, IVS help in optimizing the PCI result and are associated with better procedural outcome in hospital and also long-term outcome and mortality. Newer modalities like 3D OCT, what I showed, metallic stent optimization, you can see like tunnel inside. That offers a better view for bifurcation stenting. These are, you know, the guide where to put the second air, all these technical details you can see and do it. These techniques helps in visualizing the stent strut after stent implantation in greater detail and can detect unexpanded and malposition with creative. So we have been using in my lab around 20 to 30% of cases. We mostly use OCT because that's more clear. But in cases where there is a renal failure, osteal disease, severe lipids dysfunction, we use intravascular ultrasound. So I am a proctor for the OCT. I go all over the world to teach. But I think now, presently, when you are doing complex interventions, you should have these imaging modalities to get a very good result, immediate and long term. Thank you for your attention.